I'm the CEO of La Maestra Community Health Centers in San Diego. And I'm just going to give you a little bit of background about the clinic, about what we do, our circle of care, and then you're going to see how those Promotora models that I'm going to be specifically talking about are so effective with our populations and why. But I wanted to ask, because you're here for a specific reason, like how many of you do you have Promotora programs? So maybe I can gear some of this towards you, or are you interested in more Promotora programs in public health across the board? Okay. The Denver Authority, who's here? Yeah. Okay, great. So then we'll talk about some of the models that have worked for us. Okay, great. Perfect. So I wanted to introduce Alejandrina Areizaga. She's our COO, and she will be answering some questions as well. And Alexei, who will pop back in, he's on our board, and he is the one who leads our developmental, like community development efforts. He helped us with our green building that we finished 2 years ago. It's a Gold LEED certified building, 36,440 square feet. After 20-some years being in very old buildings that I'll show you in a minute. And there's John Lafine. He's the director of our imaging. So if you have any questions about imaging at community health centers, it's with us. We're the only one in California, by the way, who has mammogram on site in the community. We borrowed good money to have this done. That's after working 20 years with the community and finding out that it's a huge challenge for these women after you screen them and you're out there talking about why they need to come in for screening. Where do they go? How do they get there? How do they communicate? How do they qualify? It's a huge deterrent. So this kind of looks like on the left when we first opened in 1990, and this is the building that we have now. So it's really cool. You know, how we started was we started off as in 1986 as a nonprofit educational facility. We were English teachers, English as a second language, vocational training. We developed curriculum. We had a licensed preschool. We did family literacy programs, computer literacy, financial literacy. We had 12,000 students, and they were all interested in applying for the amnesty. You remember the amnesty, the IRCA, Immigration Reform and Control Act of 1986? So all of those classes were geared to help them. And when we found that a lot of the parents were bringing their kids on site so that they could attend the classes, well, you know, we started the preschool. And it was fascinating because of those 12,000 students, 9,000 did qualify for their permanent residency. And then they went on for their citizenship and applying for their families and so forth. So it was really fantastic. Those people of that student council, because they would meet every month, they said, we need culturally competent health care here in our community. We need to go to a place close by that we're not going to worry about. Are they going to let us in? Are they going to give us an appointment now or in 6 weeks? Are their providers going to understand us and our background? Do they have staff that speak our language? Do they understand our culture? Do they want us here? You know? So we thought, well, that can't be that hard. We'll just add on, you know, we'll go find some part-time doctors that are used to working in the community. So that's what we did. We started with a pediatrician 2 half days a week. And quickly that grew to, you know, gosh, here you have prenatal situations going on. You know, got a little time bomb here. So we went out, got some OBGYN. And then it started with, okay, my aunt's got diabetes. What can I do with her? You know, my mom's sick. It just grew and grew and grew. And you'll see some of the services that we have now. All of the services that we've developed over all of these years have been in response to the need that comes in the door. So right now we have about 44,570 patients. Visits was about 177,000. This is not counting the non-medical visits that are huge. We have over 26 languages spoken every day in our health center, the main one. And we're at, we're in 6 different sites now. Plus we're in 4 schools, and we have a mobile clinic, 7 dental clinics. Our biggest model that started years ago is medically trained cultural liaisons. That's like a promotora. You know, if you got a good salesperson, they can sell anything, right? But you got to train that salesperson so A, they're not out there confusing the population. 2, make sure they're not selling anything else on the side. Okay, this is amazing. People are very entrepreneurial. And 3, make sure that they're not just out there talking. They have to be able to link the people back up. Make the appointment now. Help them determine eligibility now. Otherwise, you're wasting a huge opportunity. So our cultural liaisons from all of these languages, these people work with us. Don't think that, you know, we hire people just to stand there to translate. No, they work in the clinic. And so they understand the challenges. They understand why it's so important to ask or verify this information and not to, let's say, answer medical information. Don't triage. Your job is not to triage. They have enough training to understand that. They have enough training to understand confidentiality. So when they go back at the end of the day to their public housing or low-income housing, as is in our case in San Diego, we'll talk about that in a minute, they live among all the populations. We don't want them out there gossiping, right? Talking about who came in for what. No. So we got to put them through the training and so forth. So it's real important that we have these languages available, not just for our services in-house, but when our patients are referred to hospital specialty care, even though we don't get paid for it, we end up doing a lot of the translation. Otherwise, the hospital can't get that patient consent. They don't understand what they're consenting to. So let's see here. Innovative models, the Circle of Care, which we'll see in a minute, that cultural liaison program, which is training people from those populations that have had background either in the refugee camps or in their own countries, express an interest in further training. And then we identify them that, hey, they're great to work with their population. Yes? Right now, it's limited to the schools that we already are in providing medical services. And they wanted us to go there to do dental. We said, look, there's no way, it's not effective going and installing all these operatories in these decrepit old buildings that you're not going to be able to get licensed for anyway. It's not cost effective. So have this mobile go around to the campuses. And so we started with that. Now we also are going out to El Cajon, which is East County, South Bay. But so we have to really coordinate what else is going on those days. So one day it'd be out in East County, let's say. Another day be in Central and be in the schools and the WIC programs, whatever we're doing, health fairs. Yeah. And it's much easier to go with a mobile onto their campus. The other reason to convince the district is, it takes so long for them to approve anything. What really gets their attention in a big hurry is to say, you know what? Students will remain on your campus. You will still be getting the ADA, the Average Daily Attendance Grant funding. Okay? Right away, they pay attention. So even if your clinic is 3 blocks away, no, they want it there. So integration of services is super important. We came up with this design before, basically from whatever area you come in for service, importance is for that person to know and to be told, hey, we have other services that you could benefit from, you or your family. This is what we've come up with now. If you see the red, that's all medical, dental, mental health, imaging, lab, telemedicine, so forth. The green are the other programs that we've continued to develop: job training, microcredit, microenterprise, financial literacy. Then the yellow is more community, like the health education, that we go out and do the nutrition, and that's hooked up with our food pantry, community garden. And then the blue is the housing. A lot of those buildings, we were in 14 old buildings before we moved to our new building, the clinic. We converted 5 of those into transitional housing because they were originally residential. So that population also benefits from all of our medical services and our job training and getting out there, getting mainstream. We found that 30% of our men in the, we call it I Choose Recovery program, are veterans. So we're seeing the veterans through the transitional housing as well as through the clinic services. Many people think, gee, veterans are covered through the VA hospital, all of them. So we've been, yeah. Microcredit, these are for the very poorest women in the community. They don't have a job, they have a business that they have started in their home. And working with all these cultures, it's really fascinating. They're so talented. I mean, they have, for example, we started with women, this lady from Cuba, for example, she would go up to Los Angeles, go to the different swap meets, buy things, bring them down to San Diego, and then go out and resell and make money. And she's legally blind. The bus driver knew about her, and so he kind of, helped her get her boxes up. And I mean, this woman has brought in money for herself and has hired other people in her community, okay? Then we have women that, for example, are super talented, like crochet pop tops off of the soda cans into purses, into belts, into guitar bands. It's amazing. And they look like silver in a purse. And then there's another purse that's that they do out of recycled Dorito bags. You would never know that. It's beautiful. And it's so precise. And so they started this business, they grew it, and they're offering classes now at our different sites for other women that want to learn. And then we secure them places to go and sell these products that they make out of recycled materials. I mean, it just takes a life of its own. Now, there's others that cook. The one lady was making tamales. And in order for her to get the contract from the different restaurants, she had to produce many more than she could in her oven or stove at home. So we hooked her up with a commercial kitchen, went through that whole licensing with her, helped her through that, and now she's like producing 5,000 a week or something. Again, bringing in that economic development into the poorest communities, providing that stability and financial needs for her family, and hiring other people. And it makes so much sense. So, for example, they have to come, first of all, they have to be nominated by somebody else in the program. They come to the weekly meetings required. We help them do a business plan. They have to open a bank account, a savings account, so they learn how to start saving. They have to develop a model for their business. And we teach them about financial literacy and so forth. And then what their goals are going to be, realistic. And then they meet every week to talk about what happened. Were they successful in this week's plan? Weren't they, and why? Which is where we have found a lot of other challenges that then we can provide them a warm referral into the clinic. For example, domestic violence is huge among this group. incest issues. They say, oh, I was going to go do this, but, I think my son's on drugs. He's coming, he's having these issues. I don't know who to talk to. Who could I get him to see? And so there's this wonderful opportunity to either bring somebody from the clinic into those groups so that they can get to know this person and develop a bond and be able to talk. And they can just come in and say, oh, I'm coming in today to talk about domestic violence and what it is. Or if there's specific cases that need immediate attention, we will refer them over. But again, it's another way of integrating all of these services. So anyway, the woman can get $250 loan. She repays it. She goes up back and forth that same $250 loan about, 5 times? And then she can qualify for $1,000. So we're the bottom level of, the loans and income. The only other program that's, Acción has been around for a long time, but they will loan monies, let's say, I think it's $8,000 to $20,000. So you have to be up there already with an establishing credit and so forth. The most difficult part is starting from nothing. And making that network of who you can go and, sell your products. Where are you going to sell your products? How are you going to meet so-and-so? And it's that networking is so fantastic. So these groups meet every week. And then they pay back like $19, a week, something like that. If they don't pay it, the person who recommended them pay it. That person doesn't, the group does. So the rate of repayment is fantastic. Why? We need that because we are funding this program. The way we first started this is the clinic got a line of credit from a bank, and we're using our line of credit to do these loans. Well, now the bank has seen, my God, look at the rate of return. The bankers, that's what they want to see, right? That's first. Then what were the successes of the program, right? When they see that rate of return, they're like, okay, we'd like to now contribute some to this program. So that's how we've now started supporting more and more women. Yeah. Yeah, and the difference between that and the micro-enterprise is micro-enterprise, let's say the clinic starts it or under our foundation, and we have partners, and those partners are members of the community that are interested in, learning how to run a business, like our janitorial program that uses green products. A lot of our guys from the ICR, the I Choose Recovery, are there. So they learn how to run that, and then they can go off and start their own and contract, actually, for those services. Our linen company is another one. We're spending how much money as a clinic for a linen company to come in, clean our lab coats, our towels, and so forth. We're getting ripped off right and left. The more sites you have, the less control. They come in, they bring a mat. You didn't even know they brought the mat. Pretty soon they're delivering surgical towels, okay? Nobody tells you, hey, they brought how many surgical towels. Got up to $6,000 a month with this business. So I said, let us see what we can do to bring this in-house. Again, this is another micro-enterprise. Created jobs, we keep it in-house, and we're in control, and right away we saved half on everything. And the jobs that are created, they go around picking up all of the linen, and then they clean it, they press it, whatever, they hang it, wrap it back up, and go back and deliver it. And it gives them something on their resume, too. So those are just some examples. Let's see here. So basically, because we didn't start the clinic back, the first, we didn't start up as a clinic, let me put it that way. So we came from the field of education, from literacy, whether it's child, adult, vocational. We also had great collaborations with other community-based providers that really offer these programs and are entrenched, like WIC programs, Head Starts, legalization programs, things like that. So when we became a clinic, and now we're a clinic for 20-some years, you add that into it, our ability to get out there and get the message out is huge. Now, one of the things that we learned, big lesson, was when you're working with different cultures and you're trying to get the message out, and the result is to get people to behave in a certain way, whether it's accessing services from a preventative standpoint or complying because you have a chronic disease, whatever it is, you have to be able to deliver that message in a culturally competent way through people that they're going to respect and make it something that is acceptable to them, doesn't turn them off. You know, like the way that we go out and we do breast cancer screening outreach is very different among the cultures. Some cultures do not want you to get out there in front of everybody and show these flip charts, okay? They won't go there. Others, for example, you know, big lessons that we learned, and again, it's from these cultural liaisons that are promotoras, because they're educating the providers and the people that are trying to get the funding to start these services. So they tell us, you know what? Our people don't believe in going and getting the test for diabetes because they think that's what causes the disease. Okay, well, unless we knew that, how much money we're going to waste and time getting out there with no success? Unbelievable. So each culture has their own ideas. They have some, you know, misconceptions that were from back home. Some things it's just because they haven't lived here for how many years. They don't know. Or for example, the county of San Diego spent how much money putting the message for health on the back of the bus. All right? Well, a lot of our cultures are not going to say, not going to think that that's where they're going to find valid, pertinent, believable information is on the back of a bus. It would be like us putting it on the trash cans out there. You know? That's really the way, you know, the way it goes. So with the Sudanese, for example, we found that, all right, the best way to go through that is working with their faith-based organization and working through the elders of their community. Once you go there, you meet the elders, and we're talking thousands and thousands of people in this community, then you can go through and basically talk to the people, and they will know that what you're saying is believable. They will trust you because you've now been, you know, given the seal of approval, so to speak. And it just doesn't stop with listening to what you're saying. It's making that appointment, going forward for that service, following through with, you know, let's say information about chronic disease that maybe you don't relate to because back home you never heard of your parents dying of these diseases. So you're like, nah, that doesn't, it's not me. This doesn't apply to me. Well, yeah. So when you start seeing your neighbor with breast cancer, you're from Somalia, and you never heard of anybody dying of breast cancer back home, you're going to pay attention. So it's super important to always be connected to our staff that are from these cultures and have them on every planning of everything we're doing, whether it's the design of our new building, whether it's developing the patient-centered medical home models, whether it's doing the services out in the school, in their area, or in their public housing. Let's talk about the public housing for a minute. In San Diego, this is some of our pictures. In San Diego, years ago, the city, the county stopped building public housing. So the only ones that are left are huge, they're decrepit. like, what is it, John Adams Manor, Alexei's got like 2,000 people living there, more than that. So what they did instead was they contracted with private owners of properties that wanted to upgrade their apartments or whatever it was, their houses, bless you, and give them money to make it decent, and then contract for the public housing, subsidized housing. Our list for Section 8 is like 7, 8 years long now. Yeah, the waiting list. Super. So when we first became a grantee for the public housing program, I remember Captain Bob Arundale was our program officer, and he came out and he said, you know, in your situation, it's public housing / low-income housing, because the low-income housing projects have all been subsidized in one way or another by the federal government to basically have this housing for the people. And you can see with 8-year waiting list, it's just incredible. So housing is a huge issue for us in San Diego. And what we do is we work with the CDCs. We already talked about this. The CDCs, that's the Community Development Corporations of each neighborhood. And some of them will have, like, for example, in City Heights, in our main area, it's the City Heights Community Development Corps. They own 9 different huge properties that they manage. All these apartments, and they're all subsidized. So we work with them, and we send them mobile. And there's a school next door, so we'll do the health fair. So at the same time, it's for the people of the public housing. We work with the school, the WIC programs around there, the local businesses. We'll have somebody come out and do, you know, face painting for the kids. Somebody else will bring a Jumpy Joy. One of the managed care plans will do that so that the kids are attracted, and they tell their parents, oh, let's go over there, you know. So they kind of drag the parents over. And then have our mobile clinic attracts, it's a wonderful marketing tool, we didn't know this, out in the communities. They see this beautiful van, and they're like, wow, there's something I really want to go see there. It's attractive for them. Have we had a picture of it yet? No. Okay, this is telehealth. It's one of the areas that we're expanding so we can bring more specialty services to our patients without them having to leave our centers because of the languages. And this is the digital imaging at La Maestra, how we grew, how we started with ultrasound just for prenatal, then we added the general ultrasound, and then we're able to take care of those issues right there in the clinic before sending them out somewhere. Then mammogram and the echocardiograph, let's see here, DEXA scan we do. Now we just added x-ray. Okay, there's the mobile. And it is amazing. But most of it is to capture the attention. That's what I found. Capture the attention, build on our collaboratives out there in the communities, and then do some screenings, whether it's oral, dental screenings, and the breast cancer screenings, and then link them in to a medical home that's close by. That when they go there, they're going to see the same people that were there registering them. Because now we've given, like, the little tablets to our outreach people, the Promotoras there, so they could sign them up. They could make appointments for them right there out in the field. Super important. And then they check back with those people that they referred over. Hey, did you make it? How was your experience? So it's not just out talking. They have to complete the circle. Let's see here. So these are health issues that, I'm sure many of you can recognize. And then, and then some of the other Alzheimer's, dementia, we have programs for some of our programs for seniors are like the Senior Promotora model. And what it does is it goes to the low-income housing for seniors specifically and talks about anxiety, depression, and so forth. I mean, that's another link that we have into, the public housing. But in reality, a lot of these seniors, you're going to see them coming to work in the community garden. You're going to see them coming in for the classes under the microcredit programs. You're going to see them in line at the food pantry an hour and a half before the pantry opens, because that's where they found a place to socialize. And they have no role. They have nothing to look forward to, a lot of these people. They're not hooked into a family. They're on their own. They're depressed. So if you get them involved in activities, their health is going to get better. They're going to get more in tune. And however we can do that, we're going to do it. We're starting up arts and culture classes for them in the morning, teens in the afternoon. It's all related to health. A lot of folks don't seem to understand how wellness is beyond just a trip to the doctor. So anything we can do to emphasize that. These are some cultural factors. Also, like we did a calendar on recipes from different countries, and then looking at it from, have our nutritionists look at it and suggest other ingredients, that could help the people with diabetes or so forth, obesity. And, these are actual recipes that when we have health fairs, they cook and they bring to share. Really cool. Now, some of the other issues, because we have cultures that have different family dynamics, and when they come to this country, it all changes. And it all contributes to that sense of lack of respect. All of a sudden, they don't have their position in the family anymore. They're not a source of power. They are not the ones making the decisions, and they're kind of ignored. They don't really have a role. And so we're trying to address those issues with the family, with the families. What can you do with your mom that is sick, but you haven't been able to spend money on your mom taking her in to the doctor, and she doesn't qualify for any program, and she's not well enough even to help you watch your kids now so you can be working. And now you've noticed that she's very forgetful, and you don't know what to do. These are supportive programs like the one we have that's a caregiver support program. Because the caregivers are the ones that really pay the price. And it's educating the communities on dementia and what else? Dementia, Alzheimer's, and so forth. It's really incredible, because the population will say, some of the populations will say, oh, I don't know what happened to my mom. She got in a fight with her sister years ago, and then ever since then, she's not right. It's like they don't understand. This is a disease. This is the way you see the symptoms. How can we help you get your mom into a clinical trial program, because that's the only thing there. Maybe she could qualify for some medication. And then the big thing is once you do the assessment for the, Alzheimer's, dementia, and so forth, the last specialist that needs to put like the whole seal of approval on it before you can get your loved one into the clinical trials is the neurologist. Well, we have like 9 in San Diego, and how many take our Medi-Cal or are uninsured? Not very many. So the list is super long. So that's one of the reasons that we're going after the telemedicine. Because the neurologists generally don't sit there and touch your body. They look at all of the results that have come in, and they make their assessment. So, San Diego does not have a county hospital. There is no county hospital. There is no county clinic. So people can go either to the emergency room or they can go to their local community clinics. And community clinics do not all have the same range of services, the same comprehensive services. So, or the same languages. And we have how many managed care plans that we've contracted with? 4 in San Diego, used to be 7. They gobbled each other. as we knew was going to happen. And now with the whole, ACA approaching and so forth, we've heard from the state of California that there's like 13 approved plans that are going to be out there targeting uninsured through the exchange program. We don't know how that's going to happen. We just know there's still going to be lots of uninsured. So we are positioning ourselves, gearing up for expanding on our Promotora models that are already there. All we're going to do is train them about all of the importance of getting in if you don't have insurance and seeing if you can qualify and helping them do that. So my advice would use the programs you're already using for outreach, health education, community outreach, whatever you call it, and train these folks on this. Because these people are very adept. They love working with people in the community, and that's what you want to stick to. A lot of the managed care plans, when they started up in San Diego, made the mistake of bringing people in from other counties, from Los Angeles, San Francisco, wherever. Didn't know anything about the community. And they were going to get out there because they were so successful up north, and they're going to come down there and be successful just because? No. So these are, some reasons why Promotoras exist and why use them and why invest in them. I mean, we have never gotten funding really for Promotoras, ever, outreach programs. There was one year that the county of San Diego, it was back in 2000, gave about $50,000 to each clinic in San Diego and said, hey, we just want to support your outreach programs. I mean, why? We don't know. So we took it, and after that, there was no more funding for that at all. And we already had our Promotoras, and we kept them. Many other clinics didn't. They just hired them for that year, and then they got rid of them. Well, now they're going to be up the creek because all of that time was missing, all those years of wasted opportunity to develop those linkages in the community, and that community to trust you that they know because they've seen through personal experience that by contacting your organization has made their life better in some way. So now they're going to listen to you. Let's see here. Program topics. It's amazing what things people hear about out there in the community. Oh, it was hilarious. We had talk about medication use, misuse. Aside from the regular substance abuse that we all know about, in East County, one of our big populations out there are from the Middle East, Iraq, the Muslims, and you have the Chaldeans that are the Christian Iraqis, you have Pakistani, Afghani, all that, plus the Latinos. Well, it was hilarious because, some of the pharmacies prey on those populations. They go in and they have their prescription. The pharmacy will continue to deliver to their house every month, whether they need or not anymore this prescription. Well, they don't know, right? They know that they're not taking it, hopefully, because some of them will come in and they'll say, they'll bring this big bag. You know what? I was thinking I was going to go to the swap meet. I'm going to sell these things. I mean, it's another source of income. They don't see anything wrong with that. It's like, oh my God, no, do not do that, okay? So, real important to keep an ear on what's going on. In the old community buildings we're talking about that are still used for public housing, that are managed by property managers, I mean, they are really in bad condition. And the city of San Diego has contracted with us. We're the only clinic there that was interested in going and doing lead-based testing for the kids. Or when they discovered, the city discovered that, this park that we put in this concrete jungle here, no trees or anything, is on top of what used to be a gas station. And then they'll, all the residents will go nuts, and then they call us in to come and do testing on site. It's just, I guess poor planning, I don't know. But that's really the situation for the housing there. And these are some of the venues that we have, aside from going to the housing and working with the property managers, of bringing in certain topics, certain screenings. This is the way to go to the schools, the Head Starts, wherever you have a large population that trust whatever they're going to hear about. Could be the local faith-based organizations as well. Just making sure that whoever is representing you becomes your agent legally. So just a heads up on that. Really make sure who's representing you out there, because they can be then said to be your agent, and you're responsible for them. Where? Yes, they do. Absolutely. That's why we have them trained on our EHR. And they can, even before the EHR, you register them because we are providing services. And we are also incurring liability. And we are starting the case management now. A lot of folks think, oh, you just need to do case management when they have a full visit to your clinic. That's not true. In fact, what I think is going to happen on that circle of care that we talked about, in a few years, we're going to be so focused in the middle on case management that that's really what our structure is going to look like. Because anybody can come in from any one of those services. It's how they are case managed that makes it super effective. And, we're looking for an IT solution to manage those non-clinical services. We've checked out the cloud, some of the software, the platform programs. Of course, we don't want all these independent, one for the housing, one for the microcredit, one from the... No, we want to be able to do reports in an easy way, gather that information, so we can say, look, there's this trend going on across our continuum. For example, we didn't have this through an EHR program or something like it, an IT program. But like if you analyze the issues that people face, human trafficking, in fact, we're the only agency in San Diego that the Office of Refugee Resettlement will refer to for human trafficking cases. We work with the FBI, CIA. They'll call us to go in because we're certified providers of violent, not providers of violent crime, but you know what I mean? Yeah. For victims, victims. Yeah, I have to watch that too when I talk about human trafficking. We do no, we don't do human trafficking. So, and we've been involved in those collaboratives for a long time. Because working with the schools, we're right close to the border. There's all of these issues that are so connected. Domestic violence, prostitution at the schools, outside the schools, the gangs, drug abuse, so forth. You see these commonalities, and we're dealing with all of these kids, elementary through high school. And you see already the issues that they're dealing with already at the end. And it's like, okay, what do you do now to help them deal, to help them heal, to help them mainstream again? Okay, but then you can't help but ask, what do you do to prevent them to get here, right? And so that's where the arts and healing come in. That's where the building self-esteem comes in. Hopefully connecting with one of those seniors. Maybe they don't have a senior. Maybe their parents are not at home. They need that kind of nurturing. So we're going to see if that works. Whatever it is, they have to build a self-esteem. They have to know that they have opportunities, and these opportunities out there for careers are for them. That they don't have to take the path of their brother, their cousin, whatever, because that's the only way they made money with selling drugs, being involved with, gangs and so forth. From our areas, you usually do not see people that make a lot of money driving nice cars unless they are involved in one of those locations. Okay? Very simple. So so that's what we are attempting to do with these non-medical services as well. And those are some of the commonalities that you can see if you have the opportunity to analyze that data and listening to your program managers out there that are in the community. So do you have any questions? Yes. Right. Mm-hmm. Oh, yes, we do. And depends on what providers they talk to, they say. Like they'll have a good relationship with maybe, some of the providers that are originally from Mexico, had their practice there, are here now. So that'll be one of the questions that they're going to ask them. And say, Senora, and so what are you taking? And da-da-da-da-da. Like it's an acceptable question or an answer to get. Our Caucasian providers will never ask that question unless it's on the form. Are you taking any other, over-the-counter or, traditional medicine? What is that? No. So it's the way you ask the question. A lot of providers don't want to get into that layer of complication. It's going to add how many more minutes, right? So they figure, well, somebody else will deal with it. So it really depends on the provider. Again, are they culturally competent? Are they sensitive? Do they care? It's like the whole question about the domestic violence or mental health issues. If you have a patient that keeps presenting with how many symptoms that can never get to be cured, okay, you're going to have that filter of questions. We had a training for our doctors on survivors of torture. And for them to get sensitized on issues to be aware of and to even ask these questions. Also about human trafficking. Could be for sex or labor. I mean, if you throw in one question every once in a while, like, oh, does somebody else keep your ID? Does somebody else keep control of your money? Or do you feel like you don't have freedom to go outside when you want to? You can just pop it in every once in a while. It's going to flag. It's going to flag. Mm-hmm. We don't have, no. We do have Greeks in the community, but they've already come in, 50 years ago. And they don't live in our neighborhoods anymore. They live up north of the 8. They have their Greek Orthodox church. In fact, yeah, I went to school with, with kids that were Greek. But now, they don't come in as refugees or immigrants. They've passed that now. And then train them. And then make sure that they're of the right tribe, and that politically they are not known for being very, aggressive or trying to promote their own tribal agenda, because then nobody's going to confide in them, nobody's going to go to them. It's a major thing. Now we're facing age differences, like the promotoras, the cultural liaisons we had for the Somali. Well, the teens, they don't want that cultural liaison. They're not going to identify with somebody who looks like their mom. Oh, no. Because that's a whole other issues going on here. So we have to make sure for our teen adolescent services, we have people that are, younger, that are more Americanized, but yet still accepted. It's really, really incredible. Yeah. And then, the food is the same way. If you, with your diabetics or your pediatricians, you're trying to counsel the families on what to eat, what not to eat more. Maybe your son is anemic, and he, maybe you're from a country that doesn't eat beans, and the provider's sitting there telling you, you need to eat more beans and more parsley. And you don't eat that anyway, right? So you're not going to pay attention unless there's some homework being done on what is it that you eat generally, that you can find here or you can grow here. That's the thing about the hierbas too. In the community garden was really a kick, because we dedicated a space for them to come in and do their herbs and their stuff. It's really cool. Any other questions? There's a lot of different ways. Primarily, it's always been people that we hire, that we train, that give reports, and that are managed. Okay? And then from there, we will add on some of the volunteer work occasionally in different areas, because they have a expertise or they have a special inroad with this or that. But they're still trained. We still hold them accountable. It's just much harder to do that with volunteers. They don't always show up. Our food pantry is an excellent, example of that. We have 2 people that we're paying. We have 4 volunteers, and sometimes none of the volunteers show up. So you're talking about having to bag all this stuff, give it out, keep track, collect the tickets. Oh my gosh. It's a nightmare. Same thing with doctors even. You get some volunteer doctors, I'm sure you've had the experience. If they can't show up, and they're a specialist, and you have how many people been waiting a month to see them, and they can't show up, they might feel somewhat bad, but it's like, hey, that elephant in the room is, well, you're not paying me anyway, Yeah. They're not involved. A lot of times, I find that, we have like a consortia, a group in San Diego. It's called the Council of Community Clinics. And, we've all gotten together around the table once a month for the last 24 years. And I've always found that, it depends on their level of participation and activity in in their community. Depends a lot on how long have they been there, how many collaborations do they have going on the outside with maybe non-health providers, and you get the sense of that. But the suggestion I would give you is to call their outreach, community education office, whatever it is, or their social workers too, and say, hey, we're from here, and da-da-da-da. If you start with the executive director or the CEO or the COO, you're probably not going to get far. Because that's another thing that they're going to have to do. And why should they? Well, really, they should because, one, that's what their mission is, to be there for the community. Two, we all submit UDS reports. Now, granted, a lot of that information is not totally adequate because of our systems that we're collecting. But, you know, we are having to answer for to the feds about, you know, the number of services we provide to the number of patients. Clinics always are interested in new patients, more patient visits. So just for that reason alone, if they're not behind their mission anymore, they should be out there, totally, pounding the streets. Talk to whichever department is going to get more motivated. And my bet it's going to be the people that work at that clinic that deal one-on-one with the community members. So it would be the outreach department, health ed, the folks that do the marketing, you know, out there, health fairs, so forth. Any more questions? I have 10 minutes. So is there anything else that you want to hear? I mean, I think you people are real gamers here at the last minute, okay, of the conference. I thought there was not going to be anybody here but us. So we said, well, we'll turn off the microphone and we'll just talk business, right? This REACH program is an example on our, where it's talking about the Senior Promotora program and the support for the caregivers, talking about Alzheimer's and so forth. There you go, expanding partnerships. So these are, you know, really reasons why, you know, partnering between FQHCs and partners. So your question here is, these are all reasons why they should already get it, you know, but it depends again who you're talking to. More benefits. Types of partners. And really, I mean, the list is endless. You can partner with anybody, everybody. Yeah. Mm-hmm. Mm-hmm. Well, it's certainly not through the medical reimbursements. Okay, yeah. We look for, you know, private foundations. You can ask the local banks. You know, sometimes, you know, Alexa and I have been working with banks for 20-some years. And financial institutions. Local, local, national. And some of them will come straight out and tell you, you know, I really believe that health is important, but unfortunately the bank doesn't. It's not a priority. Education is. Okay, bang. What kind of education? Kids, K through 12, adult, what? And we'll figure out, okay, it's going to be one of these programs, microcredit. Banks love this. They love these programs. They like tangible results. They don't, you know, healthcare services are kind of intangible. You just, you know, they can't really see them. They can't smell them. They can't taste them. There's no proof really, except your record. So that's a way of how you go about looking for those funds. So private foundations, local banks, some of the other corporations around will also support some of these programs, or the food pantry, for example. Food pantry, you go to like the feeding food bank, local food banks, Feeding America, Harvest America, and you learn who it is that provides food to your church, to some of the churches, the homeless shelters, and you just dig in there. And so it's a great way also for residents of community low-income housing. They all need these services, is the point. They're all survival services. So, yeah, and then occasionally you will see some government funding, but it'll be small, 10,000 or something. Yeah. So patching it together, fundraisers, events, that's how we do it. Yeah. So, thank you. It's kind of like, my first choice would be, okay, start at the beginning of your organization. Well, if you can't, because your organization is already there and you want to incorporate this, it's kind of like people calling me and saying from the East Coast, oh, yeah, we want to build a green building, and we already have it built, so now what do we do? It's like, okay, let's see. What you put on the floor and the paint and the design, forget it, all right? You can't do anything more about that. But, still you can do it. If you want to incorporate the cultural competency, I think who needs to spearhead it and be an advocate for it always are your top management, the board, senior management. So every time a new program comes up, or a new system delivery of care, somebody's there, oh, and so what are we going to do? How are we going to incorporate these populations? Or whatever special population you have, whether maybe you have a lot of seniors. Okay, so how's this going to fit in? Always remembering and putting it through your filter of, is this going to meet the cultural competency requirements that I know are there, or the seniors, whatever, special populations, and involved in be like a core, part of your core. I mean, it's just there. It's like IT. It's like accounting, right? Your finance department. It's there, period. It's one of your quality measures. Put it in your quality measures. So whatever QA you're doing, that's part of it. And then in your surveys with the patients, it goes through to that. Oh, so were you able to talk to somebody in your language? Because we did this survey, and 73% or more of our people said, yeah, some of them might speak English, but they don't feel comfortable getting that care in English because they really want to understand it. And it's not just the language, it's the culture, huh? Well, no, actually not. We have basic health, like the chronic diseases, translated into a lot of languages, prenatal care, things like that. But again, there are some populations, they do not, like Nuer is not a written language. That's the tribe from the Sudan, the most that we have. So the written is only going to be in Arabic, and maybe 10% of them speak Arabic. So a lot of it is how it's delivered. And you'll know how it was delivered by the questions that they ask back to the providers. If they get things or they don't. Training standpoint, I mean, if it's something new that you're incorporating right now, you got to start with, like monthly trainings. From the providers, the nursing staff, the support staff, the front office, the call center. I mean, it's super huge. It's like when we were going into the hospitals and doing this cultural competency training with the nurses and the emergency department on, you know, and the labor and delivery on our Somali women that were circumcised and they didn't understand, you know, and what the issues were with that. We had to go in and do a little background. Okay, this is where the country is. It's in Africa. A lot of people didn't know. These are some of their basic beliefs. And by the way, the reason that they're circumcised isn't because their parents were trying to torment them. They really believed that this was something good for them. You know, you got to get the whole picture. These are some of their major beliefs. They don't want to sit, you know, or let's say the Indo-Chinese, they didn't want for labor and delivery to be in a bed eating ice chips. They believe that that's going to hurt their kid. They want the hot tea and they want to move around. So you have the nurses from labor and delivery complaining to us, oh, your clients are so non-compliant. We have protocols. They need to be strapped in the bed. You know, they can't be moving around. They could be falling down. Okay, well, forget it. If you want the great outcomes, you're going to let them. Can we work together to establish something that is a compromise? Yeah. Everything different. Yeah, during the orientation, we try to make it really clear about life at our organization. And you have to like certain things, you know. I tell them it's like a honeymoon period, the probation. Except in your case, you get to call it off with no divorce, no nothing, okay? So identify it well and see if you're a match. Okay. Any other questions or anything? You have my email, contact information. If you're in San Diego, I invite you to come and visit. And best of luck to you. Thank you for coming.